Good morning, everyone. Can you hear me okay? All right, great. Well, my name is John Waits. I'm a family physician and OB by training. I'm the CEO of Cahaba Medical Care, our headquarters here in Bibb County, where you are today. Thank you guys for making the trip down. Cahaba Medical Care is a 501c3 nonprofit community health center. We get the pleasure of serving 42,000 unique patients in 27 locations around central Alabama, half of them rural, half of them urban, and we're here today to talk about women and children. Cahaba has 3 OBGYNs and 14 family medicine physicians who are board certified in obstetric care, serving in 3 different labor and deliveries at St. Vincent's in Birmingham, Medical West in the Bessemer, McCalla area, and right here in Bibb County, where you're sitting today, about 200 yards that direction, is a rural labor and delivery served by physicians, nurse practitioners, nurse anesthetists, and a broader group of physicians, nurse practitioners, behavioralists that do prenatal care. A few years ago, my colleague, Dr. Kathy Lavender, and colleagues at my alma mater, the University of Alabama, published an article in the Journal of the American Board of Family Medicine showing that 2 family physicians that did an OB fellowship that moved to rural Pickens County in West Alabama, when that hospital reopened to labor and delivery with 2 family docs, the infant mortality dropped 10 points. And these control counties, the yellow counties, were rural counties that had labor and deliveries open, and the blue counties are rural counties without labor and delivery services. And you can see the difference that made. A couple of years later, Dr. Lacey Smith, co-founder of Cahaba, and I published in the Annals of Family Medicine a study of 15 years of publicly available data. We took rural counties without access to labor and delivery over that period of time, and rural counties with access to labor and delivery over that period of time, and you can see a statistically significant 2-point difference in infant mortality, perinatal mortality, and neonatal mortality. This is not news. We have known this for half a century. Nesbitt and others in Washington State published this data back in the early 90s. This is a geocoded map of the state of Alabama of travel time for women in 1980. Fast forward 30 years, here's what it looked like in 2011 for women to drive over 30 minutes in the areas remote from those hospitals. Here's the headline from last year: driving 100 miles in labor, giving birth in the ER. Fears rise as 3 maternity units prepare to close in Alabama. 2 of those were in urban areas. One was Baptist Princeton in the west side of Birmingham, where our providers provided care. The others in the wealthiest county in Alabama, Shelby County, lost their only labor and delivery. Monroe County in rural Alabama, Demopolis in rural Alabama, rural Grove Hill Hospital. The headline is, labor and deliveries do not make money. In 2010, Dr. Lacey Smith and I approached an innovative, visionary hospital CEO, Joseph Marchant at Bibb Medical Center, with a proposal to shore up his medical staff on all channels: geriatric, adult medicine, and for women and children. He took us seriously, trusted us, and over the course of the next 10 years, we built the state's first teaching health center here in Bibb County that's expanded to other rural and underserved urbanized counties. We now have 60 family medicine residents practicing in underserved HRSA shortage areas in central Alabama, with an underserved placement at the end of training 3 times the national average, and rural placement 5 to 8 times the national average, speaking to what can happen with HRSA support in FQHCs and teaching health centers around the country. We have an OB fellowship that is part of HRSA's primary care and training expansion, and a QIF grant. We have 2 OB fellows, and this type of workforce development that HRSA has helped sponsor in Alabama covered the hospital's financial blindside, allowing them to take a leap of faith and invest in the first reopening of a closed rural labor and delivery in Alabama in half a century. This labor and delivery opened in November 2015, right here in Bibb County, again 200 yards that way, and features the normal prenatal care and advanced ultrasound that we were providing in our FQHC, but also local delivery and operative obstetrics right here in rural Alabama. It took a team of not just physicians, but nurses, nurse anesthetists, and alumni of HRSA-sponsored OB fellowship training programs and teaching health center alumni like Dr. Laura Lishman and Dr. Jamie Bishop, and alumni of the Tuscaloosa Family Medicine Residency Program, Dr. Elizabeth Lee. in the years prior to this labor and delivery being open, despite having local prenatal care, the infant mortality rate was triple the state average, triple the national average, double the state average. In the years subsequent to this labor and delivery opening, you can see the linear decline approaching the national average of a low infant mortality rate. Back to this map of Pickens County. This map is what inspired a young medical student in the 1990s to do family medicine obstetrics for his professional career. And it hasn't escaped my notice that today, not only is Pickens County closed, their labor and delivery is closed, but the two control counties of an open labor and delivery, Clark and Monroe County, in the last 18 months have closed their rural labor and delivery. We know how this story ends, statistically, on average. So, covering each other's blind side, collaborating, working together for women and children, I am so grateful that HRSA has assembled this great group of people to think about affordable access to care for women and children. And I'm glad you all made the trip, and I'm looking forward to this convening. A warm welcome to you. Thanks for being here.
Well, Dr. Waits, thank you so much for those opening remarks. I think you really speak to the heart of what today really represents, which is two events. There's obviously the Enhancing Maternal Health Initiative that we're here for, but it also falls on National Rural Health Day. And National Health Day started in 2011, because of many of the things you just said. We know about the challenges in rural communities, access to care, lack of workforce, structural barriers that get in the way of equitable access. And yet we also know that against that backdrop, folks are doing amazing things and they're making it work, and that's what National Health Day is about. It's about not so much focusing on the gaps and the deficits, they're always going to be there, but on really lifting up what works well in rural communities. And when folks collaborate together, cover their blind sides, to your phrasing, I think that's really what National Health Day is all about. So really glad to be able to be here with you to celebrate that. Really looking forward to learning a lot today. I'm neither a clinician nor a parent, so I may be the least qualified person to be at a maternal health and obstetric meeting, but I am looking forward to hearing what's going on and to learning from all of you. I think what you've talked about in terms of the challenges Alabama has is something we're seeing nationwide. 59% of rural counties do not have a hospital that offers obstetric services. That percentage has gotten worse each of the last 3 times we've looked at it since 2011. And so when you don't have access to obstetric care in a rural hospital, you have more preterm births, you have more risk for that mom, you have more complications for that baby, and so this is really a national concern. And it's exacerbated by the lack of workforce, and yet I think there are steps we can take. One of those is, like you said, more family medicine obstetric residencies. We're funding some of those through a program we have, the Rural Residency Planning and Development Grants. I think the other thing is just that collaboration, and so we've been able to invest the last handful of years in the, what we call the Rural Maternal Obstetrics Management Strategy Program. That's why we call it RMOMS, because that's a big mouthful. But the idea is, how can we all work together to make sure that there's a seamless transition from the first time that mom comes in for prenatal care early in the pregnancy all the way through 1 year postpartum. We just launched another program focused on the same sort of concept in the Delta region of the country. And so, I think these are places where we can learn from the model that you've talked about. But I also think, that sort of coordination, that sort of collaboration speaks to what we're all about here today. And so just thank you for the opportunity to come down here and join you. Thank you for the opportunity to learn. We'll take what we find out today and we'll factor that into our future program and policy. And with that, I'll turn it over to Dr. Warren.
Thank you, Tom. Good morning, everyone, and happy National Rural Health Day. We are so thrilled to be here in Alabama, and I want to thank Dr. Waits and the team at Cahaba for welcoming us and setting aside this incredible space for us to have this really important conversation. This is the 11th of our Enhancing Maternal Health Initiative events, the 11th state that we have been to. And what we've seen as we've gone across the country is that these gatherings are so important for us to hear from you about what's working well, what your challenges are, how our HRSA-funded programs can continue to support and better support the work that you are doing. And it's also been really vital for folks who are in the same community, in the same state, to learn about what each other is doing. What we have seen is that in event after event, there are new connections that are made. There are folks who maybe knew each other ahead of time, but who identify new ways of working together. So we've had health centers, for example, learn about home visiting programs in their communities and think about how they create referral pathways. We've had nurse midwifery training programs who have created new resource toolkits for their students to learn how to improve patient care and connect patients with community resources. We've had partners who have committed to promoting our National Maternal Mental Health Hotline, and so we come away from each of these events with these opportunities to work differently together and work better together that don't necessarily require any new money, but require us to think in different ways about working together. We at HRSA, the Health Resources and Services Administration, are focused on improving access to care and supporting a skilled workforce across the country. And many of our investments are in communities where there are barriers to care, whether those are economic barriers or geographic barriers, and our work is really about addressing those. We work across a variety of topics. One of our focus areas in particular for the last few years has been around maternal health. We know that in this country we face a maternal health crisis. It should not be the case in 2024 that women die during pregnancy or during labor and delivery or childbirth, and yet we do far worse than most other developed countries. This is unfortunately not a new problem. My predecessor, who led the Children's Bureau 100 years ago, wrote in a report that the United States does worse than most other countries when it comes to maternal mortality. Maternal mortality rates are on the rise, and the vast majority of cases are preventable. If I hadn't told you my predecessor said that 100 years ago, that's where we are today. Now, certainly the number of deaths has improved dramatically over time, but our relative performance has not. And so there is real work to be done, and we are so grateful for the work that you all do and your teams do every day that is making a difference. As we go through the morning, you're going to hear from a number of our grantees and partners around the table. I just wanted to talk about a few of the programs that you'll be hearing from. One, and hopefully when you all came in, you got information about our National Maternal Mental Health Hotline. We launched this on Mother's Day in 2022. This is a toll-free service available 24 hours a day, 7 days a week, every day of the year. This is particularly important because we know that maternal mental health conditions are a leading cause of pregnancy-related deaths across the country. And yet, in so many parts of the country, there isn't ready access to behavioral health services. And so it's this hotline, 1-833-TLC-MAMA, is available and provides that bridge, particularly in communities where there isn't access. Since launching that line in 2022, we've had over 46,000 calls. And it really is a vital resource for folks. And so one of the takeaways we have for today is we hope all of you will think about ways that you can help to spread the word about that hotline and make more folks aware. You're also going to hear from partners who are home visitors. Home visiting is a long-standing public health intervention where we have nurses or social workers or other trained professionals. They are invited into homes by families, and they support those families during pregnancy, during those critical early periods with a new baby at home, and then in some programs all the way up to kindergarten age. They help connect families to community resources, everything from primary care to transportation and housing, and really are a vital source of support for new parents. You will also hear from our Healthy Start grantees. We've got Healthy Start programs in 115 communities across the country. These are particularly situated in communities with high rates of infant mortality. In fact, rates at least 1.5 times higher than the national average. The beautiful thing about these Healthy Start programs is that every one of them is a little bit different because they are tailored to meet the specific needs of the community. Before going to HRSA, I spent about 15 years just to the north in Tennessee, and we learned early on what was driving infant mortality in Nashville was different than Knoxville, was different than Memphis, and was certainly different than rural Tennessee. And Healthy Start recognizes that. It really brings together a community advisory board, a community consortium to help identify what are those leading causes of poor infant health outcomes, but also maternal health outcomes, and identify community-specific solutions to be able to address that. So we're thrilled that some of our Healthy Start partners will be here today. Alabama has also been very successful in receiving HRSA funding for a number of other HRSA-funded initiatives. For example, our Integrated Maternal Health Services Program, our State Maternal Health Innovation Program, looking at ways to address specific causes of maternal mortality and morbidity in your state. So recognizing, for example, that many of those deaths occur in the postpartum period. They've worked to elevate the importance of that period. Simple things like creating patient bracelets for folks to wear. So if they show up in a clinic or in a hospital or an emergency department, and folks may not think to ask, have you been pregnant in the last year? Those bracelets can be a nice visual trigger for folks to think, maybe we should think differently about this patient who's in front of us and how we take care of them. I'd be remiss if I didn't mention our health centers. You heard from Dr. Waits about the tremendous work that is being done in health centers here and across Alabama. I would say that's true across the country. When we think about the contribution of health centers to addressing this maternal health crisis, they play a tremendously important role. My colleague Anyeka is going to talk a little bit about that further, but health centers across the country see over 500,000 prenatal patients every year, and that really brings vital access in communities where that may not otherwise exist. We've got a number of rural health investments that Tom mentioned that think about bringing together partners. That Our Moms program he mentioned has been so vital, particularly in rural areas where resources may be limited, but thinking about how you bring folks together and how they work together and really align that work moving forward. We are excited to hear from all of you today. We are committed to taking what we hear from you back to HRSA and thinking about how we use it to inform our programs. We're going to hear a little bit later today from Dr. Scott Harris, who is the State Health Officer. He is en route from another event. So while we're waiting on him, I'm going to go ahead and pass it over to my colleague, Anyeka Anadozi.
Thank you, Michael. Can everyone hear me? Okay, just making sure the mic is on. Good morning. My name is Anyeka Anadozi, and I am Deputy Associate Administrator for HRSA's Bureau of Primary Health Care. I'm really happy to be here sitting at this table with all of you and really ready to sort of dive into the meat of the conversation. But before I do that, Michael talked a little bit about HRSA's health centers, the HRSA-funded health centers, and I would be remiss if I didn't share a little bit more. I'd be slacking on my duties. But first, before I go in, thank you, Dr. Waits and the team here at Cahaba for hosting, and to all of you for being here. As you all hopefully know, HRSA's Health Center program is a cornerstone of our country's healthcare system, especially for individuals and families who are uninsured, enrolled in Medicaid, living in rural, remote, or underserved areas, struggling to afford their health insurance copays, experiencing homelessness, residing in public housing, or otherwise finding it difficult to find a doctor or pay for the cost of care. Because this is National Rural Health Day, I'm going to talk a little bit about the rural side of our work. So HRSA-supported health centers like Cahaba and Watley's here too today, here in Alabama, are vital for many patients in rural serving areas because they ensure that folks have access to affordable, quality, and cost-effective primary health care. Fiscal year 2023, HRSA provided more than $2 billion through the health center program to about 564 health centers that serve rural populations. And so these health centers serve more than 1 in 5 rural residents. So that translates to 9.7 million people that live in rural communities use these health centers. HRSA remains committed to ensuring that folks living in rural communities have access to high quality care. And this extends to our maternal care work, which is what we're here to talk about today. In fiscal year 23, HRSA invested more than $65 million in what we call our Quality Improvement Fund. And this was focused on maternal health. So we gave 36 health centers in 25 states, including Alabama, upwards of $2 million to really focus on ways to move the needle around maternal health. And Cahaba was one of the recipients. I don't want to steal their thunder because they'll talk a little bit about what they've been able to do around managing chronic conditions such as hypertension, diabetes. But I did want to share that of the 36 QIF maternal awardees, 12 of them serve a rural population and collectively serve 9,200 rural patients. So with that, I'm going to segue to the roundtable because that's why we're all here. And you all are the experts around the table. I feel very strongly that while we all acknowledge the difficulties around maternal health and where we need to improve, I also strongly believe that the solutions are around the table and in this room. You all know what to do, and it's just about coming together to get it done. So with that, I am going to kick off. We're going to start with the Delta Regional Maternal Care Coordination Program. We just heard from Tom earlier, who highlighted the critical intersection of rural health and maternal care. So as we continue this discussion, I want to recognize the incredible work happening on the ground, supported by HRSA's Delta Regional Maternal Care Coordination Program. This initiative is designed to enhance perinatal care access and coordination in the Delta region, addressing disparities that disproportionately affect communities like the ones we're discussing today. So we've got some representatives here from the West Central Alabama Area Health Education Center, one of the grant recipients doing this work. So I'm going to start with Adrienne Collier, who is the Senior Program Manager and MCC Project Director at West Central Alabama at the AHIC. Adrienne, as a Delta MCC awardee, how does this initiative build on your existing collaborations, like the Southwest Alabama Healthcare Collaborative? What strategies are you implementing to improve maternal care coordination and reduce disparities, especially in these rural counties with significant access challenges?
Good morning, everyone. Can you hear me? Good morning, everyone. We're so happy to be here. Would you mind repeating your question again? The mic kind of threw me off.
No, it's okay. It's a long one. We just want to hear more about how you've taken this initiative to build it on your existing collaborations, okay, and what strategies you're implementing to improve the work in the counties that you're working in.
Well, in a previous grant that I've worked on, and one that we have now, which is called our Core 4 Implementation 4, where we focus on opioids, we had this piece that was a disparities impact statement, and it focused on maternal care, pregnant women in our service area. So working on that and building upon that, once we got this grant, we've done wonderful things and made great strides with that, because we do have a virtual maternal health support group that meets on a monthly basis, where we speak on everything from anxiety and depression to hypertension to diabetes in pregnant women. So we're hoping to build upon that groundwork that we've done here with the maternal health support, with the maternal care coordination grant. In addition, our work plan calls for CHW's, community health workers. We plan to put them out in the communities, and as he spoke about going door to door, we're going to make 2 of those for community health workers doulas. As you know, there's so much help that is needed within the home, as I think it was Dr. Waits who spoke on, whether it's when the lady first has the baby or when she has the baby, help is needed there. So that's what we're trying to do with our maternal care grant. I'm not sure if you guys know about Alabama and maternal health care, but we know that in our rural counties, we can always improve and expand upon it. So that's what we at West Central Alabama hope to achieve in the next 4 years. Thank you.
Thanks, Adrienne. That's awesome. And I think the use of community health workers is always essential, because they know the people that we're trying to reach, and they are truly the front line and the best messengers. I'm going to pivot to a very beloved program, the Maternal, Infant, and Early Childhood Home Visiting Program, as we lovingly call MICV. So for those that don't know, the MICV program is about strengthening families by connecting them with home visitors who provide critical support, education, and resources. So today we've got 3 individuals whose experiences illustrate the profound impact of the program, from the dedicated professionals who deliver the services to the families who benefit from them. So we are going to start with Araceli Altamirano. Did I get it right? You sure? Yeah. Okay, because I don't want to butcher people's names. So Araceli is a bilingual parent educator, and she serves 2 rural counties and works closely with many Spanish-speaking families. Araceli, as a parent educator in these areas, what are some of the unique challenges your families face? And then how do you effectively support those families that have limited access to services and resources?
Good morning. Again, my name is Araceli. So the way that some of the challenges that our families, specifically the Spanish-speaking families that I serve, face are obviously applications or resources are mostly offered in English. So that's where I come in and obviously translate it for them, or I try to find these resources in Spanish. Them coming from a different country, obviously maternal care is different here than it is there. So everything is new to them, even from applying for emergency Medicaid, because that is what they qualify for. Explaining to them that emergency Medicaid only covers the delivery and not the prenatal care or the lab work that may be necessary. In ways that I've helped them face these challenges is, one, I let them know that, you know, it's very important to stay on track of these bills that they're going to be getting, but I help them arrange a payment plan so they don't feel overwhelmed. Another issue that we also see is that, you know, serving Cleburne and Clay County, the closest OBGYN and hospital is 40 minutes. So we arrange, you know, family members or friends to give them transportation, or we also let them know about the great resource Medicaid offers through, I believe it's the net card, I'm not sure of the correct name, where they call before their appointments and they're offered reimbursement for traveling, you know, the gas expenses or whatever. We help them with that because even though we help with a lot of things, we're not allowed to transport them ourselves, you know, for liability issues. We also let them know of transportation, public transportation, if available in the counties. And it's one of the two main issues that I've encountered with the families that I serve. Thank you.
Thank you, Araceli. And all of that work is really important. It's those, in the health center, we call them enabling services, but all of those sort of wraparound supports are sometimes just as important, if not more, than the care itself. Because if you're not able to get to where you're going, or to eat, or to take care of financial issues, the rest of the stuff sort of falls apart. So thank you for what you're doing. All right, next I'm going to introduce Tina Barnes, who's been a home visitor for over 10 years and brings a wealth of experience, including her previous work with Head Start. Tina, you've worked with families for decades. How do you build trust and rapport with the families you serve? And how do you empower them to take an active role in their own well-being and decision-making?
Good morning. My name is Tina Barnes, and I have been in the system for a while. One of the ways to get trust with your families is always to be consistent. Going in, keeping our appointments, keeping our visits. We go twice a month into the homes. So you become their family. You become somebody that they trust. A lot of times, we are the only person that gives them positive impairment. If they don't have a good support system, we go in and support them. And especially in our area, we serve 15 counties. So in our area, we're very rural in a lot of the counties. So the parent educators go into the home and they become that person to empower them. And especially with our prenatal people, we go in and we encourage them to keep their visits. You know, we do the PHQ-9, which does for depression. We do breastfeeding assessment. We do the at 6 weeks, and then 8 weeks we do the postpartum. We encourage them to keep their visits. We show them how the sizes of the baby at all times. We discuss what's happening, taking place into the baby. And just being there for the family seems to that's how we build a trust with them and stuff. So I'm not sure what else.
No, that was great. Thank you. I think we can all appreciate the power of consistency.
Yes.
And the importance of that. Thank you for all the years of service.
Thank you.
And your continued years. Now we're going to hear from Julie Gallagher, who's participating in the program as a caregiver to her 2 young nephews. Julie, you mentioned that times have changed since you raised your own children, and the tailored support you've received through the Parents as Teachers program has been a big help. Can you share how your experience with Parents as Teachers has impacted you and your family, and what aspects of the program have been most beneficial in supporting you on this parenting journey?
I think for the most part, resources. I'm really loud, so I probably don't really need this. But because 3 years ago on Thanksgiving, we got a phone call about a nephew that we didn't know had been born. So we are now parenting 2.0. We have a 3-year-old and a 9.5-month-old. So I didn't know what I didn't know. Car seats are different, cribs are different. So I've really been given some tools to create the safest spaces for my kiddos, not only physically, but emotionally. Both my kiddos are born exposed. I think we're gonna see a lot more of that in the coming years. And so I can know where they should be on those normal charts, where I can get additional assessments, where I can get additional help. Because in the rural community that we currently live in, that we are not natives to Alabama. I don't know if you can tell. I didn't know where to get that assistance, but the Parents as Teacher program is very well advertised, and so you can make a phone call and they will call you back. It's not like some of the agencies that I'm still waiting for a call for one of the Mother's Helpers, Mother's Day Out programs, and 2 years out. So that has really been impactful for us, and just knowing that I can call them and go, okay, this is going on. Is this normal, or is this something I should bring up at our next pediatrician visit? Because we live 45 minutes from the doctor. We live 45 minutes from town. I am not used to having cows as neighbors. And so we have gotten a lot of those supports for my kiddos' journey. Anything else?
No, thank you, Julie, and what a blessing you are to your nephews. So thank you for stepping in the gap that way. Great. All right, we're going to switch gears a little bit and talk to our colleagues in the Maternal Health Research Collaborative for Minority Serving Institutions. And so we're going to shift to our guests, Attorney Crystal James and Dr. Latrina Thomas from Tuskegee University, which, as we all know, is one of the premier universities here in Alabama. These folks are distinguished participants in the Maternal Health Research Collaborative for Minority Serving Institutions. This particular HRSA-funded collaborative is designed to address the persistent disparities in maternal health outcomes that disproportionately affect racial and ethnic minorities. And before we go further, Crystal and I were talking privately, but I also want to acknowledge publicly from HRSA, our heartfelt condolences go out to the entire Tuskegee University community. We are grateful that despite everything that's going on and the challenges you all are facing as a campus and as a community, that you all still made the effort to be here. So we appreciate that, and what it really reflects is your resilience and unwavering commitment to the work of maternal health. So apologies and thanks and gratitude for being here. So Ms. James, could you tell us about the 4 key pillars of your initiative and how they address the unique challenges faced by women in Alabama's Black Belt?
Yes, and thank you very much for acknowledging that. We are looking to move forward, but it has been a very rough couple weeks. Thank you for the opportunity to be here. As a 1890 institution, we are mission bound to serve the communities in which we sit. And as we heard from the presentation earlier, the service areas in which there's now accessible delivery services is few and far between. So for our first cycle of this research center, we are focusing on 3 Black Belt counties that do not currently have any OBGYN service in their counties. So these are the women that are traveling the 100 miles or more in order to receive any service. The other thing, having come right out of COVID, we learned through that process that it's not only accessibility, but acceptability of services that make a difference in the healthcare outcomes of people of color. And it also has a lot to do with trust and trustworthiness of providers that are available to them. And so in collaboration with our community partners, we came up with 4 strategic pillars that we plan to focus on for the next 4 years that are going to be in a framework of an action plan that is community engaged and focuses on nutrition to build a culture that fosters sustainable and healthy eating habits, as not only before pregnancy and during pregnancy, and also as we talked about after pregnancy, as you continue into that breastfeeding journey, that the nutrition that is very important for that. And having the, being the home of George Washington Carver, we also have the pleasure of having those relationships across all of the Black Belt counties and those extension services, so that that framework for trust and trustworthiness has already been laid through those services. We also want to focus on access to care to improve navigation support, some of which we've already heard here today, through within our healthcare system, and also establish some long-term programs for community health centers. One of the things that we're really focusing on in that vein is listening to those nurse midwives and doulas that have been catching babies in these communities when they could not make it to the hospital. They have things that we can learn from. We plan to capture those stories and share them widely so that we can also continue to improve those outcomes. Also, one of our strategic pillars is mental and physical health, increasing family health history awareness and promote family planning, pre-pregnancy, health advantages, and postpartum warning signs. And last but not least, education and training to develop faculty training programs for community health workers, certificate programs for those individuals who are in nursing. We do have the first baccalaureate nursing program in the state. We continue to train nurses with, and one of our co-PIs is a nurse midwife who has a dedicated focus to making sure that we get those folks with that increased knowledge in MCH, as well as for our Master of Public Health program, creating a concentration for those individuals going into public health that will have a concentration in maternal child health with a rural lens. We are also seeing how we can look at what's going on in other rural countries and hope developing some similar questionnaires so that we can actually start to see what are some of the, not just differences in demographics, but the approach to the care in postpartum, because we know that there's something there that countries that are supposedly lesser developed than us are actually doing much better in postpartum than we are. So they have answers that we need to tap into. So I'll stop there. So thank you.
Thank you so much. There's so much richness in there, so I'm really looking forward to seeing the results. I think that the fact that, and I'm hearing this theme a lot, the answer just being within the community. So you're reaching back to the doulas have been doing this work before it was titled such, and training that next generation and expanding the perspective globally to see what's going on around the world. That's really exciting. All right, we're gonna switch over to health centers. I'm not partial or anything, but I am. So as we continue exploring the critical work being done to improve maternal and child health, we are going to talk about the HRSA-supported health centers. I mentioned earlier how they're a cornerstone of care for underserved communities, and they provide comprehensive care. But we're going to start with the Cahaba team, our hosts, and they're going to talk a little bit about what they're doing. So here we have Dr. Jamie Bishop, who's a family medicine obstetrics physician, an alum of the HRSA's Teaching Health Center Graduate Medical Education, or THCGME, we love acronyms in the government, if you haven't noticed, and the Assistant Rural Residency Director at Cahaba Medical Care. Dr. Bishop's leadership highlights the vital role of advanced training programs in preparing clinicians to meet the needs of rural and underserved communities. We also have Dr. Kaylin Goranson, who is a family medicine obstetrics resident physician currently training under the THCGME program, and Charity Lassiter, who is the Director of Behavioral Health. And together, these folks work and they exemplify the power of comprehensive and compassionate care in rural settings. So I am going to start with Dr. Goranson. Can you tell us how your experience in the THC GME program at Cahaba and UAB has shaped your ability to provide comprehensive and compassionate care to rural communities?
Yeah, so like they've said, I'm a third-year family medicine resident and one of the rising OB fellows for next year, and I'm tacking on an ER fellowship to that too, so I'll just be a resident fellow forever. I grew up and did my medical school training in New Jersey, so I wasn't exposed to the FMOB model or just kind of concept of care until, to the surprise of my family, I moved to Alabama for residency training. At the time, I really just knew I wanted to practice rural and serve rural, so that's what initially had me do the trek down. Early in intern year, we all get exposed to prenatal care, working in the OB clinics. As residents, we're on call and oftentimes running to the ER to triage a patient who may or may not be in labor. If they're not, a lot of times we're coordinating their follow-ups back in the office across the parking lot, like Dr. Waite said, 200 yards away. Or we're admitting them to the labor and delivery unit. We're following them through the labor. We're catching those babies, quite literally, and then doing their postpartum care, infant care in the hospital, but also in the outpatient setting. So for me, it dawned on me at some point, as someone who, most of us I think who come into family medicine want continuity and want those relationships with patients, that I had these patients on my, or following up in, in our panel, or as kind of my panel now, where this mom may or may not have had primary care before, may or may not had ever been screened for depression, anxiety before, Hep C, high blood pressure, diabetes, I mean the list goes on, maybe didn't have a PAP, and was now due, or we found things that we need to follow up on. This mom has been now set up with Cahaba. They know the clinic, they know the behavioral health team that saw them through their prenatal care. They're on our sliding fee, potentially, or maybe they were set up with social work and they had some, they broke down some social determinants of health barriers and got them some level of insurance. So it just dawned on me that yes, I have this infant that can be on my panel for the rest of my career, but this mom has a true primary care provider, true patient medical home, like that she can come back to and get not just her postpartum care for a year or so, but for decades. So once I was exposed to that, there just kind of was no turning back for me. So anyway, pursuing the OB fellowship side of things.
Well, I'm sure your parents may have been shocked, but the folks of Alabama are happy to have you.
They're still confused.
So Charity, you lead the QIF work at Cahaba. So as the Director of Behavioral Health, you've led efforts to integrate mental health services into maternal care, address challenges such as substance abuse, intimate partner violence, and perinatal depression. How has this approach improved maternal health outcomes, particularly for rural and underserved mothers?
We've seen significant benefits for the patients and also just for our providers, as Dr. Goranson mentioned. Our family medicine physicians and social workers enjoy the integrated work that we've done with our mothers and being able to address the social determinants of health, also addressing those risk factors that we're aware of as far as depression, previous episodes of depression, previous episodes of intimate partner abuse. All of those things play a role in substance abuse and how the mothers and infants' outcomes postpartum. And so we've been addressing that in an integrated format within Cahaba, just by screening mothers for all of those risk factors throughout their pregnancy, and then again postpartum, and partnering with behavioral health and medical care together.
That's excellent. We have Dr. Gwen McKenzie from Whatley Health Services. I wanted to give her an opportunity to talk about what they are doing at Whatley. So Dr. McKenzie, can you share how Whatley Health Services addresses the unique maternal health challenges faced by underserved communities in Tuscaloosa?
Hi, thank you. Glad to be here. I've been at Watley Services. I'm an OBGYN trained physician. I had retired for many years and came to Watley out of retirement about 3.5 years ago because they needed an OBGYN there. Hadn't had one, I don't think, and I'm not even aware of one being there. They may have had many years ago. So women's health there, we do obstetrics, where we see patients come in. I see them clinically. I don't do the deliveries. We work with the University Medical Center. Dr. Lavender is next to me. In their program, they do the deliveries with their OB family medicine fellows. So when I came there, it was very eye-opening in that I had no idea, serving in private practice in Tuscaloosa for many years, to come and see our underserved of Tuscaloosa. We have a very large Hispanic population, immigrants from Guatemala, mainly, a lot from Mexico, Honduras. We're in the west end of Tuscaloosa, so a lot of African American patients. I have a lot of international students, PhD candidates coming in, so I have many international students from all over the globe come in. So we serve them, I think, better now that we have an OBGYN. Before, our family practitioner, nurse practitioners are mainly seeing them. We had a family practitioner doing obstetrics. She was not an OB trained family practitioner, but she did the best she could there. Currently, it's just me, and I've trained a nurse practitioner who is a family practitioner, nurse practitioner, to help me with women's health. So I basically have trained her the last 2.5 years to see women for GYN problems and taught her about obstetrics from the ground up, basically. She had absolutely no experience, had never done even a pelvic exam. So we do a lot, we see a lot of obstetrical patients. We have a lot of high-risk patients, more so than I ever had in private practice. More because of our population, we have a lot of gestational diabetes, a lot of pre-gestational diabetes, a lot of marijuana use, not as much drug use, but some, other than marijuana. A lot of STDs, a lot of syphilis and pregnancy. That's been eye-opening in our state now with new mandates for syphilis treatment during pregnancy. Preterm deliveries. Gosh, it's been very, very busy there. So, so we're serving this population, doing the best we can, but I see that we need a lot more help with people trained in women's health, nurse practitioners that are trained in women's health coming there. We definitely need more OBGYNs. It's just hard to recruit people there. And I think that's been a roadblock. It's hard to recruit nurse practitioners. It's hard to recruit MDs, DOs to come and serve this population because they need desperate help. And I'm happy to be there. After being in private practice, which now I see what's very easy, it's a luxury to come there. It's been eye-opening. We're served with our interpreters. We have 2 interpreters that are just, we could not operate without them. Unfortunately, I think both will be leaving soon. So, that's a huge problem in our rural health, I think, services that, if we don't have them, it's extremely difficult. I found it very difficult to use my phone, to use an online interpreter. If I have someone there, our patients, they know our interpreters. They love them. And they're open to them, and they see them consistently. We talked over there about consistency. The consistency is so important. They see me or my nurse practitioner every visit until 36 weeks. They trust us. They trust our MAs. I have a bilingual MA who's great. They've seen her for years. So they know that we're there. They know that they speak their language, and that's very important to them to bring them in and to tell their friends to come in. But we see a lot of barriers. Transportation is a huge barrier. Fear of, initially I saw fear of deportation was a huge barrier. They didn't want to come in until delivery time because they thought someone would tell on them. A lot of patients just don't see the value in prenatal care. So that's been a problem. In Guatemala, they are in villages. They don't have prenatal care. They just will deliver in their home. So we have to teach them the value of prenatal care too. The value of vaccinations, the value of, the infant care. So it's a lot of work, but we need more people. And so I'd like some feedback on how to recruit in our community health clinic would be great.
Actually, your remarks are a great tee up because we're going to talk about workforce in a little bit. So I think hopefully that will answer or help you get some of the answers that you need. But thank you for standing in the gap the way that you have and training the next group of providers. Before we get to the next folks, I did want to acknowledge Scott Harris. I know you walked into the room as the Alabama State Health Officer, and I know that you had some remarks. So I'll let you get your sea legs, or unless you're ready to speak now, and then we can pivot. Okay. Okay. So let's hear from two patients of Cahaba first, and then we'll come back to you. Does that work? Okay. We are here. I'm excited that we're joined by two patients, Madison Panther and Kiera Martin. They have lived experience that I think will bring invaluable insight to this discussion. I mean, we've talked a lot about the provider perspective and sort of the climate, but I think brass tacks, if we're not serving the patients the way we need to, all of this is for naught. So I really do want to hear from the two of you, and I'm glad that you all are here to share your stories. So we're going to start with Madison. Madison, can you share how your experience as a patient at Cahaba has impacted your journey through pregnancy and motherhood, and what supports or services have been most helpful to you?
So I'm Madison. I'm 30 weeks pregnant, so almost there. I'm from Washington State, so very different. I was very close to my hospital, very close to my doctor's offices. Now I live about 30 to 40 minutes away, but having everything here, it's a one-stop shop. It has made my experience so easy. My daughter goes to the pediatrician here. You just get to form the relationships with the providers and the medical assistants. You really become like family. They check on you all the time. I know if I need anything, I can call any of them and they will get me right in. They will answer any questions I have. And just knowing that I can 200 yards away deliver my baby and then come straight to the doctor's office and all three of us can be seen, so I'm not running around to different doctor's offices. And just knowing that they actually care and they will listen to you, and that just makes it a lot worth it.
Thanks, Madison. I think the beauty of the one-stop shop cannot be stated enough. Kiera, hopefully I'm pronouncing your name correctly. You sure? Okay. As a patient receiving care at Cahaba, what have been your most meaningful aspects of your maternal health journey, and how has Cahaba's care influenced your overall health and well-being?
Okay, so I agree with most of the stuff that Madison said. The one-stop shop and being able to go right across the street to deliver my baby. My experience was great. I had my baby in September, and they all treated me like family. I felt loved. They always checked on my mental. That's very important to me because I suffer with depression. They take you in with love, nothing negative. They always check on you no matter what. Postpartum, I don't know. I get nervous talking around people. Sorry.
Don't be nervous. Don't be nervous.
Dr. Bishop took care of me. She is so sweet. She's like a second mom to me, honestly. I wouldn't, if I can go back 7 years and pick who I want to deliver my babies, I would deliver here with all three because, like I said, they treat you like family. I would do it all over again just to have that experience. I'm just playing.
Thank you both. It's so heartwarming to hear that you both got and are getting the care that you need and deserve, quite frankly. So thank you both for sharing. You ready to give your?
I can't really follow that. that was terrific. I apologize for being late. I had a meeting at the same exact time 200 yards away that somehow got double booked. So, but thank you for letting us be here. I just want to welcome you here. We have several folks from the Alabama Department of Public Health here. We really appreciate our federal partners being here. Thank you for allowing us to do the work that we need to do in our state. You make it possible for us, and we're very grateful for that. Also very grateful to be here with Dr. Waits and Cahaba. We're so fortunate to have this organization in our state. It's tremendous, and I just can't say enough about the fantastic work that they're doing here. Our fundamental drive in public health is that we think everybody ought to have a fair shot at their best health. That's what gets us out of bed in the morning, and it shouldn't matter how much you make or what your skin color is or how far your parents went in school. We believe everybody deserves a fair shot. We particularly concentrate on our most vulnerable people in our state, and our moms and babies are the ones that really need extra attention. And so we don't always have the levers to pull that we would like as a state government agency, but we certainly do care very deeply about these issues and use the population health tools that are available to us. I'll mention we're sort of weird in Alabama in that the Children's Health Insurance Program resides in public health. CHIP is an ADPH unit as opposed to residing in Medicaid or other as a standalone agency like I think literally every other state. And so that's really important for us. We've just recently been able to expand coverage to women when they become pregnant using CHIP, and technically it's unborn child coverage, but practically means that moms have access to prenatal care and throughout their pregnancy, and then the child, of course, is eligible for CHIP at birth. So we're very proud of being able to do that. We have a lot of other initiatives that we're doing around safe sleep, that we're doing around preconception, interconception, chronic health management that we see in our health departments, at least from a population level. We are working on, again, many safe sleep initiatives, many other things. There's more need out there than we can meet. But certainly your support is really important to us. So again, thank you for letting me be here.
Thank you so much. So we're going to shift now to workforce. So as we talk about workforce development and enhancing maternal health outcomes, it's essential to recognize the impact of specialized training programs and the dedicated professionals in this field. So we are going to start with Dr. Catherine Lavender, who is an associate professor in the Department of Family, Internal, and Rural Medicine at the University of Alabama. As the director of the Division of Family Medicine Obstetrics, Dr. Lavender oversees programs that train physicians to provide comprehensive maternal health care, especially in rural settings. Dr. Lavender, as the director, how is your involvement with the primary care training and enhancement, community prevention, and maternal health, here we go again with these acronyms, PCTE CPMH program, how has it influenced the training of primary care physicians in maternal health? And can you share specific strategies of initiatives that you've implemented to enhance maternal outcomes in the communities you serve?
Sure. And I will refer to that as the program from here on out because it is a mouthful. So we will talk about workforce development. So I'm with the Tuscaloosa Family Practice Residency Program where we train 48 residents every year in primary care and family medicine specifically. And so this program has allowed us to expand our obstetrical footprint in that program by offering additional experience with ultrasounds and maternal mental health and things like that. Specifically, we have established a OB training track, so residents that are specifically interested in obstetrics can take extra electives during their second and third year of residency, where they are getting more exposure to rural obstetrics, because we are in Tuscaloosa, so we're kind of a suburban area. So we specifically place them in rural areas for part of their training. We do more emphasis on maternal mental health again with those in the OB training track. We do ultrasound education and things like that. But our OB fellowship program probably has benefited the most. So this is a 1-year additional training for family medicine residents that would like to deliver babies and perform cesarean sections and really be that rural workforce that we're talking about that's going to really impact maternal mortality in our rural areas. So because of this program, we've expanded our OB fellowship from 1 or 2 fellows a year to 3 fellows a year, so expansion of that program. We, again, have increase their rural training, because what we're finding is we need to train in an urban area or a suburban area to get numbers, but yet if we never train in a rural area, it's pretty terrifying when you've had all the support of a NICU and subspecialist to then go out and be the only person in a rural area. So we have found that at least having them spend some of their time in training in a rural area has helped give them confidence as they graduate. We also do partner with Whiteley Health Services to provide care for a really resource-poor population. And how do we do that? And I really will say our fellows love coming to Whiteley. That is one of the highlights. It's a really hard day for them, but it is one of the highlights of their education, and they do learn a lot about the pathology there. One of the most interesting things that we've been able to do, I'll talk about 2 of our programs, is a maternal mental health clinic. And so we know that for most women, they are going to turn to their OB provider, that especially in a rural area, their OB provider is going to be their most trusted professional. And we may refer them to behavioral health specialists, but a lot of times I find they don't want to go, they don't have transportation, they don't know them, they don't trust them, but they do trust that doctor that's been with them throughout their pregnancy. And so we are training our fellows to really provide behavioral health services to that population. And we have established a maternal mental health clinic once a week where we work with a family physician who has done a fellowship in behavioral medicine to work and teach that to those, to really integrate that maternal mental health. And then finally, I'll mention telemedicine. So we have done a pilot program with telemedicine where we allowed, the grant allowed us to give some technology to our patients to do some telemedicine prenatal care from their home or their workplace. I will tell you that we learned a lot from that feasibility study, and we are closing that feasibility study because of the things we've learned. But the interesting thing, or the fabulous thing, is that we are rolling into another pilot program with the Alabama Department of Public Health, where our patients will be at their rural county health department and then do telemedicine with our physicians. And so we are really excited about that partnership, and we hope to launch that very soon. And again, this grant has given us the ability to do that. And then finally, I'll mention that our education doesn't stop when they graduate from our fellowship program. So we have been able to develop a CME program where we have weekly free CME offerings for our alumni, and we've opened it up to some of our community physicians so that they have access to just hearing the latest topic on treating hypertension in pregnancy, or we had one on maternal depression recently, and so we're excited to be able to offer that free for our physicians that are graduating as a continuing medical program. Okay, thanks.
Lots of great things happening in your space. I think hearing the experiences with telehealth, it's great to hear that. I think there's something to be said from learning from things that don't work and pivoting and trying something new versus abandoning the whole thing altogether. So there's a lot of great stuff going on. You're expanding the fellowship program, you're integrating maternal health, and you're looking for different ways to incorporate telehealth in ways that'll be more effective. So thank you so much. Next, we're excited to hear from Dr. Hannah Marshall, who is a resident at the University of South Alabama Health and an active participant in the program. I'm borrowing your thing because I'm not doing these acronyms again. In the program. Dr. Marshall's work reflects the program's mission of preparing clinicians to address the unique challenges faced by women in underserved communities. Dr. Marshall is a resident and a participant in the program. How has your training prepared you to address the unique maternal health challenges faced by women in rural and underserved communities?
So like she said, my name is Hannah Marshall. I'm a third-year family medicine resident. I'm currently living in Mobile, but I'm actually from Barber County. So I'm outside of Eufaula, about I think 270 people in the last census. So I'm definitely no stranger to rural Alabama, the challenges that poses, and what living in a remote area looks like, especially when you live in a town where there's probably about 4 times as many cows as people. And our satellite for our internet that I only got in my senior year of high school, I believe, was on a water tower. So, you know, taking those experiences, going from a very rural area to a city like Mobile, which is huge, definitely has different challenges. So I went from the nearest primary care doctor was half an hour away in my hometown to, you know, a specialist is an hour away. The nearest labor and delivery unit is an hour away in Dothan, an hour and a half away in Columbus. So that was normal to me. And then I moved to Mobile, and I'm 12 minutes away from work, 5 minutes away from Walmart, 5 minutes away from Whataburger, you know, so life looks different, but it still has its challenges, especially with maternal care and primary care in general. So working at an FQHC, working at a program with a fellowship for obstetric care has been an incredible opportunity. So I've, you know, gotten to work in Dothan. I actually delivered the first baby in the hospital that I was born at, and so hopefully can go back there, but take the training that I've received in Mobile and in this training program back to the community where, you know, I was born, that raised me. And, you know, the experiences that I've gotten in Mobile have been incredibly valuable for that. Just learning not so much, you know, yes, you need to practice evidence-based medicine. Yes, you need to follow the guidelines. But when you have a patient that you haven't seen in 3 months because they've got, you know, 3 kids at home and don't have reliable health care, they live across state lines, they work, you know, a night float job and, you know, a serving job, and they don't have transportation and they have to take 3 buses to get to you, you don't look so hard at, well, I need you back in this office in exactly 4 weeks, or so help me, you know. And so, you know, we really are blessed to have a social worker in our clinic to provide resources for them, to give them bus waivers, to help them, you know, enroll in insurance and teach them, you know, here's your resources for breastfeeding classes, here's why you even need to take a prenatal vitamin, and what the importance is of a diabetes screen and why we need to diagnose these things. You know, it's invaluable. And so, you know, it's been a great experience, but it's also been incredibly eye-opening. So, but yeah, I'm very excited to be here and to learn from everyone, and thank you for having me.
Of course, and I love that full circle moment you were able to have by delivering in the hospital you were born in. You're definitely a testament to the success and the importance of these programs, so thank you. We're gonna shift over to the Healthy Start program. So for those that don't know, Healthy Start works to improve health outcomes before, during, and after pregnancy by addressing disparities and connecting families to resources and education. Today we're joined by a diverse group of participants who are helping to make a difference through their roles with the Healthy Start programs across Alabama. We are going to start with Ms. Wakina Carter, who is a parent educator with the Mobile County's Healthy Start Enhanced program. Wakina works closely with teens and young families, helping them to feel supported through parenting classes, group meetings, and connections to resources like doula services and WIC. Joaquina, Mobile County's program focuses on teens and young families. What are some strategies for engaging young families in services and ensuring they feel supported and empowered to access the resources they need? And what role do parenting classes play in fostering that sense of community?
Hello, everyone. I'm going to highlight our monthly group meetings, our group connect. We have a variety of different speakers to come out and speak with the young parents and young ladies. We have topics as to nutrition, counseling, breastfeeding. We have the doulas at each meeting that we have the doulas on board to speak with the young lady. We have someone from the Alabama Career Center to work with the young ladies for job placement or to assist them if they want to get back in school. We do activities, vision boards. We eat together. We do brunch, breakfast, lunch, and we also have activities, an activity center for the kids. You know, they don't have childcare, bring the kids. We have activities set up for them. We do self-care, like we do spa day. We just make it fun. The girls, they connect with other young parents. They share ideas. Well, a form of support for them because some of them really don't have it, and they meet friends. They come in alone, maybe isolated and shy. They connect with the other young ladies, and they leave as friends, and it's very rewarding. And what was the second question?
Now, these are long questions. The role the parenting classes play.
Oh, no, the parenting classes have been very, very rewarding to the young ladies because some of them, they don't have support at home. They don't have parents. They may, some of them live in shelters. So when they come in and get the parenting classes, they appreciate it. They learn how to be better parents, not being so hard on themselves. So it's very rewarding, and I enjoy it.
That's awesome. That sense of sisterhood that you're building that's essential. Thank you for that. Next, let's hear from Irma Brooks. She's another parent educator within Mobile County's Healthy Start program. And Irma's been doing this work for over 3 years. She helps connect families to vital resources, including Mobile County's Baby Store. So, Irma, can you explain a little bit about how this store works and what items or resources are available to families through this initiative?
Absolutely. So we have what's called our baby store, and it's actually on site. So our participants, and we do service young women in between ages of 10 and 24. So they are able to come to our location and actually shop in the baby store. We have everything they may need for their babies. If not, we will go get it. Strollers, car seats, diapers, wipes, bottles, pacifiers. Like I said, we have everything. So at the time of enrollment, we give them what's called a baby bucks book. So they accumulate points. And we don't only use this for them to just shop in a store. We use it as a push for them. It helps them to reach goals because the items in the book may say you get 10 points for coming to Group Connect. You get 15 points for making AB honor roll. You get points for receiving your GED or taking your baby to the doctor, even going to their prenatal or postpartum appointments, they receive points. In turn, they take these points and they come to the baby store and they're able to shop. So they don't have to use actual money, they use the baby bucks. And this gives them a sense of providing for their babies without having to ask anyone for money. Because again, like I say, some of them are very young. So they're excited when they come to the store and able to purchase a car seat for their baby or a bottle or even a blanket. So like I said, we use this as an incentive, but also as a little push for them to go to the doctor. They know if they go to the doctor, they'll get these points. You know, if they reach this goal, they'll get these points. So it's very rewarding. And when I first got there, I thought it was very interesting to have that on site. And we have it set up like an actual store. So yeah, they really enjoyed that part.
That's a really creative solution. That's awesome. Thank you, Irma. All right, so we're going to shift gears a little bit and talk about engaging fathers in maternal health. Fathers are an often overlooked but critical aspect of family support. So we are here with Stephen Garrett. of the Fathers in Action. He's the Fathers in Action coordinator with the Gift of Life Healthy Start. As a father of 5 and someone with a background in community programming through his barbershop, Stephen is passionate about changing the narrative for fathers and empowering them to be advocates and active participants in their families' lives. Stephen, can you share what inspired you to join Healthy Start, and what resources or programs do you offer to help fathers? And most importantly, why is it important to engage fathers in maternal health?
First, good morning. Second, I might need you to share the rest of that question again. Well, I'll start with the reason that I was passionate about Healthy Start was I have a background, not to get too long-winded, but my wife, we have 5 kids. And so the initiation into fatherhood was not the best. She did not receive the best care in the first, in her initiation as a mother. And so as a young man, I had to be an advocate for. One of my beliefs, as well as my supervisor, is outside of the mother, the strongest advocate is an educated father. And so we cannot build strong families or help in maternal health if the ones that benefit the most from the mother's health are not educated about the role that they need to play. So that's how I got involved with Healthy Start, and it aligned with my passion.
I'll repeat the other questions. So what resources or programs do you offer? And then you talked a little bit about the why, but if you want to talk more about the importance of fathers in general.
One of the programs that we do, and it's probably one of the best things I think that I have seen, is we connect the resources and the education portion to the father. Years ago, right before I came on, my supervisor explained to me they had a called a Family Feud. And so we have these co-parenting groups, and during the co-parenting groups, sometimes we'll have the games. During one particular co-parenting group that I was privy to be able to get some insight on, there was this Family Feud where they asked the questions based off maternal health and the development of their child. Well, the fathers won, which did something to the mothers, but it's because we're passionate about monthly making sure that they have their parent as teacher handouts, and we're giving them the education on what they need to do, what they should be looking for. But also, when the fathers are going in, I was telling someone earlier, we have the privilege of serving a multiplicity of fathers. So in the co-parenting groups that we have, and in the parent as teacher handouts that we are able to give out, what we've discovered is that some of the fathers that you would think were the best equipped sometimes don't feel as equipped, and some of the fathers you would not expect to be as involved are even more involved. I have one father, he is 20 years old, and I have the privilege of serving him. I was telling someone earlier, when we made our last visit, he had sat down with the mother. They've already developed several programs of how they're going to tackle her pregnancy. They've developed a safe word for when she feels uncomfortable in the doctor's office, that he knows it's time for him to step in. After the baby made it here, because of our help in goal setting with the father, both of them have had the ability or developed the ability to goal set for their own personal time, because we talked about postpartum after and the signs. We've had fathers that have called in. One of the things Gift of Life offers, I think is beautiful, is we have a counselor on staff. We've had fathers contact us and tell us, I think my spouse or the mother of my child is exhibiting some signs of postpartum depression. And so now we can connect with the nurse that is associated with the mother. And then we're able to say, hey, to make sure that she understands that we're not hearing anything that is said private. I just want to let you know that the father has said these are some signs that after his study, after the knowledge we've shared with him, that these are some signs that she's showing, and for you to start looking for some of those things. So now the nurse is going in there with a different view, because the father is seeing that mother in private times. You can kind of put on a good facade when you have to put on a facade, but it's hard to when you are dealing with someone on a day-to-day basis. And I'll say this on the why one more time. One of the biggest reasons why, I was in a meeting the other day with a father, and the child has been dealing with some purple crying. And so the father has told the mom, because he works all through the day and he comes home late at night. So the father has said, listen, when I come home, I'm willing to take on the role and you can get the rest that you need. Well, one of the issues while I was sitting down meeting with him was, she said, he just seems so mean sometimes. And I said, well, tell me how he seems mean. When he's crying, when the baby's crying, he tells me, go to the room, close the door, I'm here. We have a bassinet swing, put him in there, let the baby stay there, let's watch over the baby, and then you can rest, and we'll just come and check in on the baby as time is needed. And so she said, but that seems so mean. How can you allow your child to cry? I said, well, let's look at the purple crying handout that I sent you all. And when she saw that what he said was verbatim to what the handout said, it made her feel some type of way for a quick moment, but it also made her feel comfortable in expressing that she wasn't okay and that she felt some type of way about leaving her child, even though she knew it was the best thing for her child. So part of the reason why is because I believe, again, an educated father can be the best mode of defense for that mother and her health in the process of the prenatal and in the postpartum.
Thank you, Stephen. You all are doing excellent work, and I know from my own personal life, I would not have been able to raise the two daughters that we have without my husband. So the importance of an actual solid partner that cannot be stated enough. So thank you. All right, next we're going to move to the State Maternal Health Innovation Program, and this program focuses on implementing innovative strategies to address maternal health needs. It empowers states to test new models of care, address health disparities, and implement strategies that have a tangible impact on the well-being of mothers and families. I'd like to introduce Christy Plump, a mom and the Director of Community Engagement and Health Equity at University of Alabama's State Maternal Health Innovation Program. Christy, in your role as the Director of Community Engagement and Health Equity, you facilitated focus groups to inform the Maternal Health Task Force strategic plan. How has your own experience as an Alabama mom shaped how you approach this work, and why is it important to center community voices?
I wrote your questions down, I've learned.
Hello,
everyone.
My long questions.
I'm fighting the urge. Let's acknowledge this cute mama and baby in the corner. Girl, so many people want to hold your baby in this room. And I'm also fighting I got a new shirt, and I really want to stand up so everyone can see it. But let's stay focused. Let's stay focused. Thank y'all for being here. Okay, listening sessions. Let's start there. So we hosted 9 listening sessions across the state from July to September of this year. Some of you in the room were able to attend. 6 were in areas deemed urban metropolitan. 3 were in areas deemed rural. We did hear no surprise to anyone in this room, different things in the rural sessions versus the more urban metropolitan. And then I would be remiss, Britta and I are twins. We look just alike. We work on the same project. And then Martha is who corrals us. Also, we're UAB. I wrote our cute letters here. Yes, let's acknowledge these acronyms. They are out of control. Let's all acknowledge that. But the listening sessions, what we heard from mothers in Troy was not that they were bothered, which we were surprised by because all of us live in urban areas, that they were driving an hour at 2 a.m. when they went into labor. It was that the isolation hit them in postpartum, that they were disconnected from resources. 4 themes we heard during the listening session. Again, none of these are surprises to anyone in this room. Education, resources, support, and respect. We will have a nice, flashy, very pretty report that will come out in 2025. But those are the soft topics that we heard thus far. Also, our job is to be friends with everyone in this room. As you have seen, Britt and I, we're taking copious notes, and we're going to contact all of you because if we haven't already, because our job is to increase collaboration, innovation. We're about to be best friends, okay? We're definitely doing focus groups for fathers next year, which we might not need to do. We could just talk to you. But the AIM part, which I'm also here to talk about, we have the bracelet project, which you all have heard. But one thing that I think definitely needs to happen is that I wish all of the work in this room was publicized better, which thank you, cameras, because the bad news is real splashy and the articles are real loud. But mothers found so much comfort in our listening sessions knowing that someone was thinking about them, just knowing. Some of these mothers told their stories as if it was their first day telling about their labor and delivery experience, and their child was older than I am. And we had mental health support at each session, and those women worked. Someone was always leaving out of the room. We had to pause the one in Selma because the stories were so impactful. With that, the bracelet project, which did not exist 2 years ago when I gave birth to my son, I have pictures. I love to show pictures of him because I pick out all his cute outfits. But I was a readmit, and it was very scary. And so I appreciate the work that everyone is doing, but yeah, there's a lot of work to be done. We have 7 pilot hospitals for the bracelet project, but we're taking it statewide. Thank you, Blue Cross Blue Shield. I'm not sure if any of y'all are in the room. I'm happy to talk, but we are going to talk to probably everyone here. So thank you, HRSA, for bringing all our friends together because we're taking it to the top. But
we'd love to hear it.
But in all seriousness, as an Alabama mother, speaking to all these mothers, hundreds of mothers during these listening sessions, the women in Alabama are ready to receive the help that I believe we're offering. I think there is a bit of a misconception, and things look different post-COVID because we've heard that hospitals offer these prenatal classes, they're offering breastfeeding support groups, and people aren't necessarily signing up and attending. But I also have been a patient and can speak to how hard it is to acknowledge some of these websites to go sign up. And there's privilege in me having 30 minutes on my job to sit on the phone with someone to register for said classes. So there are some barriers there that we definitely could learn from the patient experience, which everyone in this room is an excellent listener. We just gotta let folks know we're thinking and fighting for them. I haven't figured out how to do that yet, but the cameras, new shirt, are helping.
You're doing it now. You're doing it now.
Thank you.
Thank you, Christy. We also have representatives from the Integrated Maternal Health Services Program at UAB. We are fortunate to be joined by Anna Marie Wallace. First off, congratulations to Mom, who recently gave birth to baby Charlotte. So she's here today with her new baby, twin toddlers, and her nurse, Kim. And their program integrates a variety of maternal health services. Anna Marie, besides the clinical help you receive from Kim when she checks in on you and Charlotte, could you share a little bit about your experience getting connected to additional services during your pregnancy?
Well, I certainly wish that I had known about them when I had my twins 3 years ago. But with Charlotte, it was my first time bringing home a newborn. With the twins, they were in the NICU for over a month, so I didn't experience any of that. And she connected me with all the resources that I needed that I didn't know existed with bringing home a newborn, even though I was already a mom. Sorry, I got distracted.
That is perfectly all right.
New mom brain. Can you repeat it?
Yeah, sure. Just talking about your experiences getting connected and how that experience was for you. Just a little more of what you were saying.
Well, with Kim, she also connected me with a support system. I had been trying to get counseling and with different health providers and falling through the cracks. And when I met with Nurse Kim, she connected me with a counselor named Claire that works with them. And I was talking to her within the same month. And I feel like that's helped me a lot with fighting off postpartum depression, because I was really worried about that because I had it so bad with my twins. but we're looking for more of the warning signs and keeping a check on that, and they're working with my healthcare provider as well.
Thank you so much, and congrats again, and I'm glad you were able to join us, you and Charlotte.
Thank you.
Finally, we're going to hear from Claudette Poole, who is the Family Clinic Medical Director at UAB's Ryan White HIV/AIDS program. And this program provides comprehensive support for people living with HIV, including mothers navigating unique challenges and accessing care. Claudette, how do you approach the challenges of engaging and retaining pregnant individuals in HIV care, and what strategies have been the most effective in addressing the unique needs of this population?
Well, thank you for inviting me. I'm actually a pediatrician by training, so I come at this problem with a slightly different perspective. I've been a pediatric HIV provider in this clinic since 2015, but this clinic's been in existence since the 90s, right? So if we look at how the continuum of care has changed for this population, it has changed, right, from the 90s to today. But until I came on board, I didn't really feel like the model of how we were delivering the care had changed substantially. So from 2015 to the start of 2024, we had 8 babies born in Alabama with HIV, which to me speaks to the gaps in care because it is entirely preventable, right? We really shouldn't have any babies born with HIV. So I've really started looking at this issue of how do we close the gaps, and the only way we can is if we collaborate and work together. So initiatives we've put in place is really with a lot of people in this room. A lot of the patients we need to take care of don't actually live where our clinic is based. So our clinic is in Jefferson County, but the women that are affected that need the care are statewide. The babies born to these women, there are very, very, very few providers in the state who are comfortable taking care of perinatally exposed infants. It is essentially us in Birmingham and my colleagues in pediatric infectious disease in Mobile. And we have to cover the entire state. Again, that's not possible without partnerships. So things we've done that have been extremely successful, speaking about the telehealth model, we've partnered with a Ryan White clinic based in Montgomery and Dothan, where the mother accesses her care locally at her local clinic with her known social worker, delivers locally, and then we follow those babies postpartum via telehealth, but based in her clinic. And that's removed that whole need for that mom to have to travel to Birmingham just for the baby to be seen. We're trying to extend that partnership up through our clinics that cover the northern part of the state. We're collaborating with Cahaba Medical and supporting their Ryan White program. The message of a one-stop shop that Madison spoke about, making such a substantial difference in her overall experience, is really what we need to do, right? Expecting a mother to have to see multiple different providers, especially those that are most vulnerable, is just unrealistic, and the maternal care, especially after that baby is born, will become the lowest priority, right? So those moms will follow up often for their baby's care, and their own care falls by the wayside. I can't tell you how many women I take care of. Well, I take care of the baby. The mother's coming to that visit with the baby, and she has not made her postpartum visit. She has not got her contraception postpartum, right? So we really need to pull in our pediatric providers if we want to capture the postpartum care that those women need to be receiving. I have mothers who've had abnormal pap smears and can't get to their colposcopy appointments, right? So again, trying to see how do we integrate their care so the mom goes to one clinic and she can access all the herself and her infant. Speaking to the value of engaging fathers, if I look at patients that I've taken care of recently, when there is an engaged father in that family unit, the outcomes are so much better, right? So we do need to look at more opportunities in how we pull in those fathers. And then one thing that I haven't seen spoken much of is how do we partner with our midwives? I'm not from Alabama, as you can tell. I'm from South Africa. I trained as a general practitioner in South Africa. I have, lived and worked in the United Kingdom. I had a baby there. I have trained in upstate, in New York. I've come to Alabama. So I have a lot of perspective of different ways to deliver healthcare. And I really think we need to look at a different way. What we're currently doing is not working. There's great models of care that are working really well in other parts. We just need to become sort of open to how do we implement them.
Thank you so much. And I think that's a great call to action for the work that is going to happen this afternoon when you all get together in small groups and start thinking through what next steps are. We've covered a lot of ground this morning. We've heard it from a lot of folks. You all are experts. You all have wisdom and experience and expertise that you all can leverage from one another. You are the answers to the problems. You all are here. You all can really move the needle on maternal care in Alabama. We've heard it. The dedication and passion and insights are truly inspiring. And this afternoon, you all have the opportunity to collaborate on solutions and the next steps forward. Any last words from my HRSA colleagues? All right. Thank you all so much.